So while we're waiting, I'm going to ask if you might take a moment, if you have signed in by phone, to go ahead and put your name in the chat box so that we know who's with us today. And we still have people coming in the door, Ben.
Very good.
All right, we'll go ahead and get started. Good afternoon, everyone. My name is Linda O'Connor. I'm the president of C3, the Caring Community Collaborative, and I have the honor to serve as your moderator today. Thank you for joining us for the second session in our conference. You can find more information on this conference and on C3's work on our website at www.c3ohio.org. I'd like to thank our sponsors for this venture, the Butler County Mental Health and Addiction Recovery Services Board, and the Butler County Family and Children First Council. Thank you also to our community partners, Lakota Local School District and Envision Partnerships, for their continued support. And I also want to say thank you to a terrific team of volunteers for helping pull today's event together. Before we get started with our speaker, let's go through some housekeeping details. If you're joining us by phone, as I've asked earlier, please go ahead and put your name in the chat box so that we know you're here. And throughout this webinar, attendees will not be visible or audible. However, we are looking forward to your participation, to your questions and your comments. And we invite you to be very involved in our process today and use the Q&A box on the bottom of the screen for your questions. And we'll take a moment periodically throughout our discussion to address those questions. And the chat box is also available for comments and questions. Please take a moment right now to open your chat box up and set the comments to go to all panelists and attendees so that everyone can be engaged in the conversation. I've also asked our speakers and our team to put their contact information in the chat box right now in case you have follow-up questions or comments for them. To our attendees that are applying for professional CEUs, your time in and out of the conference is automatically recorded, so you will not need to do that. Please address any questions you might have regarding CEUs to Joanna Lowry, and you'll find her contact information already in the chat box. Also note, if you're going for CEUs today, there'll be a very brief survey as you exit you'll need to complete in order to apply for certification. And on that note, we'll move to our speaker, Dr. Ben Ogles. Ben has led an interesting life. He was the oldest of 9 children. He was born in Whittier, California, and he moved to Brigham City at a young age. And after he began his college career at Brigham Young University, he took a 2-year leave of absence to serve as a missionary in Norway. Upon his return, Ben continued his education at BYU. His bachelor's degree was in accounting, but because of work that he did at the Timpanogos Mental Health Center during his college years, he changed his vocational focus. He enrolled in the clinical psychology doctorate program. His dissertation focused on outcome measurement in agoraphobia research. And following his internship at Indiana University Medical School, Dr. Ogles received his PhD in 1990. Ben has served at Ohio University in Athens, Ohio for 21 years as a professor and later as the head of the Department of Psychology and Dean of the College of Arts and Sciences. Dr. Ogles returned to his alma mater as the Dean of College, Home, and Social Sciences, and he became a professor of psychology in 2011. His research has been published in journals such as the Journal of Consulting and Clinical Psychology and the Journal of Child and Family Studies. He's also co-authored books. Ben and his wife have 7 children and 6 grandchildren, which makes life interesting, I'm sure, anyway, Ben. He feels very fortunate to have talented, fun, and caring children and extended family that he very much enjoys spending time with. When he's not with his family or chasing academic pursuits, Dr. Ogles enjoys golfing, tennis, jogging, and internet chess. Ben, we're really thankful to have you here today with us. The floor is yours, and please let us know when you're ready for questions and when you're ready for polls.
Thank you, Linda. It's great to be with you all today. I wish we had the opportunity for me to be back in Ohio. Loved our time in Athens, Ohio, and miss it a lot. And in fact, my associate dean. I got her degree at Ohio State, and we often commiserate about missing graders' ice cream. I wish we were back in Ohio. The greenness there. And it's great to be with you to talk about adverse childhood experiences. And I'll share my screen here so we can get started. Okay, Linda, can you see it okay, my presentation? You get the title there?
Yes, I can, Ben.
Okay, very good, thank you. All right, I'm going to talk a little bit about measurement in particular of adverse childhood experiences. And I saw this tweet this morning from the associate deans. Their handle, Ask Deans, I think says it well. And maybe some of you are dreading this a little bit, thinking that we're going to do a workshop on assessing assessment, theories on designing protocols for measures, evaluating instrument design rubrics. I'm hoping that what we do here today will be practical. And so it won't be too much research-oriented communication. So let's start first. I want to know a little bit about what settings you're working in. I participated in the first session with Mary, and she did the same thing. But I'm hoping you could tell me where you're working, and let's see what the range of the audience is.
So audience, you'll have 30 seconds to complete the poll. And the question is, how familiar are you with the research on adverse childhood experiences?
This one's the setting first. That will come later.
Then it looks like we've ended the poll. Can you see those results?
I do not. Maybe it's the way, oh, now I do.
Okay.
Okay, very good. It's very similar to what it was this morning, with almost half of you from other settings. If you could put some of those in the chat, that would be helpful, so I could see some of the settings that you're in. Okay, very good. We have really quite a wide range of people. And the great thing is that measurement of adverse childhood experiences, or getting some sense of it, could happen in a lot of different settings. And we'll talk some about that. But first, I'm going to give you a little introduction to the research history of adverse childhood experiences. Now, even before that, I'm going to tell you that I put together a nice Google Drive for you. I'm going to stop the share here and share again and let you see what that Google Drive looks like. Here you'll see that I've set up a Google Drive that has a folder with measures of ACEs, a variety of them, just some examples, some reports about ACEs, some research articles, some articles reviewing ACE measures, some research about some of those measures, the validity, and then the PDF of this presentation. So anyone that wants to, and it includes all the links that are in the presentation as well. So this Google Drive folder is already out there for you, and you can use it as you will. I'm going to stop that share again and then share my screen again back to the folder. So now I suppose maybe someone from the team, Linda, could take that. Can they copy that, or do I need to?
Our team can send that out, Ben.
Okay, yeah, if you'll put that in the chat, that link, then everybody will have access to the materials they need from this presentation. ACEs are so common, adverse childhood experiences, referred to as ACEs. It's become so commonly discussed that even NPR has a quiz that you can take online. So in essence, they're doing ACES screening right there on NPR on their website. You could go out and look at that. Now, some of the measures I'll show you later are very similar to theirs. So now the next poll, how familiar are you with the research about adverse childhood experiences? Let's take that poll and do just a minute just to see how this audience is. Are you very familiar with the adverse childhood experiences research literature or not at all?
And again, you'll have 30 seconds to respond. Looks like a pretty broad range on that as well, Dr. Ogles.
Yeah, but we've got about half of you who feel familiar, or very familiar, and even more with quite a bit. So hopefully this will be an addition to those that aren't as familiar. The original ACES study was conducted in 1998. It was in California in 2 waves of data between 1995 and 1997. It's about 17,000 people who were HMO members in Southern California. It was a cross-sectional study. It was not longitudinal, so that you get simultaneously, they report on retrospectively on their adverse childhood experiences. And I'll show you what those were in just a moment. And also, at the same time, they had a physical exam and they reported on their current health status and behaviors. And the findings of this study were impressive and meaningful, and have led to a bunch of things that we'll talk about here in a minute. The adverse childhood experiences that they had people report on were grouped into 3 categories. Abuse, if they'd experienced emotional, physical, or sexual abuse prior to age 18. If they had challenges in their household, again, prior to 18. You can see what those are, if there was substance abuse or mental illness or violence in the home, separation or divorce, or a parent was incarcerated. And finally, neglect, whether it was emotional or physical neglect. Now, in the literature since then, people have used other categories, and we'll talk some about that as well. The findings of the study were that first, that adverse childhood experiences were quite common. 2/3 of the people in the study reported at least one adverse childhood experience, and 1 in 5 reported 3 or more. And it's noted that in some populations may be more vulnerable to these, depending on their economic conditions to begin with, social economic conditions. And please note that the ACE score is created by summing up the total of categories reported, not the events. So you could have had multiple incidents of abuse, but it would count just one time because that category of kind of adverse child experience had been experienced by the person. And then the main finding was that as the adverse childhood experiences experienced increase, the number of negative health outcomes, in particular, the first studies were about health outcomes and not mental health outcomes, increased. So now I want to pause here for just a minute. Given the findings of this study and the number of participants that are here today, it's pretty likely that some of you in the audience have experienced one or more adverse childhood experiences. And if so, could we pause, and would it be okay if I invite you to do 2 things sometime of your choosing in the coming weeks or months? First, would you take a personal inventory of your own strengths and relationships and resources and opportunities that help you to survive or manage or cope or thrive in spite of those experiences? And second, if you've not already, would you consider whether you could benefit from visiting with someone regarding your experiences? I think you'll see from the research that we show here that as we go on, that could be beneficial to you, and I hope you'll consider those things if this fits you. So what happened after the original study? Well, there are a bunch of prevention efforts, And if you spend a little bit of time on the CDC website, I've given you the link there to the section on this. There are many resources for prevention related to adverse childhood experiences. And even though the original study was with adults, retrospectively reporting on things that happened to them when they were under 18, much of the research has been focused on preventing those experiences from happening or intervening with the experiences that children have in order to prevent those outcomes in the future. Screening has been recommended, and that really is the main focus of what we're going to talk about today, the measures that you could use and some of the things that you could do once you do the screening. I think the trauma-informed approaches were being developed at the same time, and the findings related to ACES certainly influenced that movement and the many available treatment approaches that are out there for PTSD and other trauma-related symptoms. The research has just expanded enormously. You see there that when I looked, which was about maybe 4 or 5 weeks ago as I was preparing for this, there were 6,677 citations for the original study. People are doing all kinds of research about this. One of the things they have done is they've expanded the number of outcomes that are predicted by ACES. For example, looking at maternal anxiety and depression, and I actually included an article about that in the folder on the Google Drive. They've also expanded the number of adverse experiences from the original 10. So for example, hardship and serious illness and death in the household have been added as things that you could experience before age 18 that might influence health and mental health outcomes. There's also been a bigger literature about child and adolescent outcomes correlated with adverse childhood experiences. Listed some of those here along with the reference, the Gilgoff study, which also that review is included in the articles in the Google Drive. So looking at things such as asthma or recurrent infections, the health outcomes, or other kinds of things like delinquent behavior or physical fighting of adolescents that have experienced adverse childhood experiences prior to when the outcomes are assessed. In addition, there have been theories created about the pathways to these negative outcomes. What is it that leads from a bad experience to having health outcomes that are poor later in life? And I'll show you the model on that in just a minute. And then, of course, there's coalescence. It's converged with this literature about resilience or protective factors and the things that help someone to thrive in spite of adverse experiences. All of those are things that in the research literature that have been discussed in the 23 years since the original study was published. So I'm going to cover just a little bit about that. So here's some of the adulthood risks that are correlated with adverse childhood experiences. And you'll notice that, the original ones were really the chronic health problems, the fact that there was cancer and diabetes and traumatic brain injury, sorts of things. Later studies then found mental illness and substance use, those kinds of outcomes, and even outcomes related to unintended pregnancy or pregnancy complications and fetal death are all more likely or have a higher probability as the number of adverse childhood experiences goes up. And then, of course, educational or occupational outcomes as well. Again, these are taken from the CDC website, and you can see a lot more information there. Here's the theoretical pathway. The idea is that adverse childhood experiences cause neurodevelopmental disruptions that then can lead to impairment in social, emotional, and cognitive functioning, which then affect health risk behaviors that can result in disease, disability, and social problems, and potentially early death. Now, one of the things to really remember here is that and I think it's illustrated well by the pyramid, and that is that it narrows as it goes up, right? Not everyone that has an adverse childhood experience has disrupted neural development, nor do they, all of them have social, emotional, cognitive impairment, nor it gets narrower as it goes up. And I'm going to share a study with you in just a minute that shows the kinds of things that interrupts that pathway. But there are probabilities here. We're talking about the possibilities. It could move in this direction, so that's why we engage in intervention or prevention efforts. But it doesn't mean that everyone who has these experiences also then dies early. That is not the case. And so often we misunderstand research when we're talking about probabilities, right? We're talking about an increased possibility, but that doesn't mean a definite possibility. So here's some cautions about that research. And this article as well I've included in the Google Drive if you want to look at it. First of all, there's a difference between retrospective and prospective reporting. The original study asked adults to think about what happened to them when they were children. That is not the same as asking an adolescent or a child what's happened to them in the last year, or to ask a parent what's happened to a child in the last year or before their 5th birthday. And in fact, when they do studies comparing retrospective and prospective reporting, the Venn diagram is such that they don't overlap. So, and you can see this in the Baldwin study. And so we got to be really careful, especially if you're in a setting where you're going to be screening in children or adolescents. For adults, you're going to be screening in a more similar way to the original studies because you're asking retrospectively as well. But if you're going to use prospective and a prevention kind of screening, then you need to be careful about assuming that the pathway is the same when you measure it prospectively and when you measure it retrospectively. Same with cross-sectional versus longitudinal. To get a really good developmental study, so you know that development influences something, you need to track it over time. So you need to measure something now and then follow the person for 5 or 10 or 15 or 20 years and look to see. So one of my colleagues who's a developmental psychologist just published a study where they found that young women, and not young men, interestingly enough, in a sample where they started measuring at between ages of 10 and 13, and they're now in their 20s, so they've been following them for more than 10 years, that increased social media use among young women was correlated with suicidal thoughts, but it wasn't in young men. Increases in social media use increase the possibility of suicidal thoughts. Well, in a developmental study like that, where you follow them longitudinally, you have much better evidence than if you measure their suicidal thoughts and their media use at the same time, and then assume that one leads to the other. And many of these studies about adverse childhood experiences have been done cross-sectionally, but the original study was done that way. So we're assuming, because we asked them retrospectively, that it's developmental, but that doesn't mean it's a developmental pathway until we do studies to demonstrate that it does. And one of the things that's crucial there is that there may be other vulnerabilities that are actually predicting these health outcomes, such as poverty. So perhaps poverty co-varies with or co-occurs with some of these adverse childhood experiences, and therefore poverty is playing a role in these outcomes in addition to the adverse childhood experiences. So we need to have good developmental studies as well. Finding that the specificity of the models limits their generalizability, and that's the same thing that I've said already, that not everyone with a high ACES score will have the same negative outcomes.
And could we take a moment there to address a question that
Sure.
we have in the chat box? Give me a moment, it just jumped on me. So the question was raised by Lonnie, and it is, what's the difference between struggling cultures and cultures of privilege in their ACES experience by age or gender?
Ooh, I don't know that, I don't have actual means. I do know that environment, especially like environments where there's poverty, for example, then there's an increase in the possibility of some of those adverse childhood experiences, such as neglect. My guess is there are some good studies out there. I'm not familiar with them, but I could try and find them and help with that. Yeah.
Okay, so you're looking at it more as socioeconomic status makes more of a difference as far as the studies you're aware of.
Yeah. Well, for example, I mean, you're more likely to have neglect, for example, parental neglect, if you don't have anything to begin with, right? So you increase the possibility for some of those adverse childhood experiences when there's poverty in addition to it.
Thank you, Ben.
Yeah. I would need to look to find specific studies for struggling groups. Okay. Okay, so I want to pause here again. Not everyone who has adverse childhood experiences has the potential consequences. So just put in the chat one thing that helps you to cope with negative experiences and one resource that could help you to cope with past negative experiences.
And Ben, while people are taking a moment to do that, we have another question for you.
Okay.
Why isn't the number of incidents of each category taken into account on ACES? Why not include that metric?
Okay, you could include that metric. And in fact, some of the later measures do. They take into account frequency of occurrence or intensity of occurrence, because the intensity of one adverse, like sexual abuse, right? It could be rape or it could be fondling, or it could be multiple times or it could be one time. And some of the later measures do try to take into account this. The original study just counted if it was the category. If you met the category, then that counted. And many of the adult measures remain the same as the original study. And then newer measures, and in particular, the Yale Vermont scale that we'll look at includes intensity or frequency. So that's a great question. Yeah.
Later measures might have more specificity toward that then.
Yes.
Okay.
Yes. I'll say more about the, yeah, go ahead.
Go ahead.
I was going to say there's also, there's sort of a separation in the measurement between measures that are focused on post-traumatic stress disorder versus measures that try to follow in line with the original study about adverse childhood experiences. And the PTSD measures tend to be more specific in that way, asking questions about intensity and frequency.
Okay. Thank you. There are lots and lots of comments in the chat room. Meditation, talking or walking, family, friends, trusted supports and connections, faith, listening to music, supportive relationships, second mothers, prayer, counseling, hobbies. I think that goes back to what Mary was saying this morning about creativity when they talk about crafting, music, meditation, lots and lots of great suggestions in there.
Yeah, it's interesting that I'm guessing that people are more familiar with their coping strategies because of the last year than they were before, just because they've had to use them so much. For a while, I was in a ecclesiastical in a church-related position where I was often talking to 18, 19, 20-year-old young people. Of course, I'm in a university setting, so I have those conversations too. And for a while, I asked multiple of these young people, how do you normally cope with stress? And I was surprised by how few of them weren't sufficiently introspective to know actually what they did. And then when we started to talk about it, and I said, often people cope with stress in ways that use the senses. They take a shower and let hot water hit them on the back. They like touch. They go watch a sunrise or a sunset. And they listened to music. And it talked about each of the senses and how people use that for stress reduction. And then if you cued them a little bit, then all of a sudden they could start to say the ways in which they cope with stressful things. Often eat with, you could find almost one thing with each. You light a candle because the smell, or you bake some cookies or bread because it smells so good and reduces stress, and the connection between your senses and stress reduction.
That makes a lot
Right.
of sense.
Yeah. Thank you all for sharing those experiences, and I hope you're using with your clients as well. So now here's this, I included this study because, first of all, because it's very recent. Second, because it's an illustration of developmental attempts to study ACEs. And third, because it includes the opposite. It has the counter ACEs. They called it counter ACEs rather than resiliency or protective factors. I think they did that because they were tied to this archival data set, and so they were looking at what was collected and then trying to figure out what may protect, but it wasn't selected based on what the literature says on it. So here's just a little overview of the study. So there's 10 to 13-year-olds, and they're assessing these children. There's, I think, about 500 of them every year. These are from the Seattle area. It's where the study was conducted. And they gathered data from them every summer for more than 10 years. And then they looked at the data and they identified adverse childhood experiences that occurred, that they reported in the first 5 years. And then they assessed the outcomes when they were between the ages of 20 and 23, so 10 years later. And the outcomes were depression and anxiety, substance use, risky sex, and body image concerns. And when you analyzed it, just looking at the adverse childhood experiences, they did in fact predict negative outcomes. So more adverse childhood experiences meant greater depression, greater anxiety, more likely to use substances, more likely to engage in risky sex, more likely to have body image concerns. However, when you put the counter ACEs in the model with the adverse childhood experiences, the ACEs didn't predict negative outcomes anymore. So in this case, the counter ACEs, and because this is a unique kind of study, I put those on the right side of the slide. And there's some reported by the children and some reported by the parent. I didn't put the wave or the year in which they gathered the data. That's available in the study. And actually, I did include that in the ACE measures section of your Google Drive. So you could see exactly which year, like was it in when they were 12-year-olds or when they were in 15-year-olds, when they gathered it. But the children, if the children reported they felt support from their teachers, they felt happy in school, if they reported high self-esteem, or they had beliefs that provided meaning and purpose, especially for decision making, if they felt socially connected to a parent, or had a positive peer relationship with their best friend, or had a good time in the previous week, those things essentially nullified or countered the effects of the adverse childhood experience, at least when it with respect to depression, anxiety, substance use, risky sex, and body image, right? And the parent, if the parent reported that they had mealtime or weekend routines, or they knew about the adolescent's whereabouts and activities, or the adolescent had good neighbors in a safe neighborhood. Those things. So that combination of counter ACEs, if you will, made it so that diminished the negative effect of the ACEs on the young adult health and independently contributed to better health. So this is why we have to be really careful, I think, about screening for ACEs. In fact, some people recommend that if you're going to screen for adverse childhood experiences, you ought to also at the same time administer a measure that looks at resilience or protective factors and include them both together.
And
And Go ahead.
Can I insert two questions here?
Yes.
So the first question, it strikes me as I look at the counter ACEs that you're talking about, that those are also something we would refer to maybe as the factors of resiliency.
Sure. Yeah. They
That,
certainly match up with the resiliency factors that are found in the literature, right?
yes.
As especially like I mean, we'll find. I'll show on another slide too, right? This one supportive adult matters a lot, right? It just matters a lot. You find it over and over again in the literature. So that matches right up with support from a teacher, for example. Uh,
Okay. And
um,
then a second question, and this is from Scott, going back to the ACEs survey that you'd mentioned in the research.
yeah.
And his question is, how do you recommend using this instrument with children and adolescents?
Oh, I'm going to come to that in just a minute. Yeah. Thank
All
you,
right, we'll
Scott.
be waiting for it then.
Scott, thanks for the prime. Yeah, we'll get to the instruments in just a minute. Okay. So this came from studies that were talking to pediatricians. And the Gilgoff says providers can advance the health and well-being of children and families by identifying children and families in need. In other words, ACEs screen. And again, this is a pediatric journal, so we're talking to pediatricians. And I put up here this other quote from the American Academy of Pediatrics because I think it illustrates how rapid this literature is growing. They say validated brief screening tools for a busy primary care setting have yet to be developed, but general questions can be used. That's just 7 years ago. And yet, if you look at the review articles that I included on the Google Drive, you'll see that they're reviewing maybe 50 different measures. So now you can't say that anymore. So just in the last 7 years, there have been many screening tools that have been developed, some of which are validated, some of which don't have good psychometric data yet. And we'll get to that. So here we are. Here we are to the instruments. Now we're going to talk about the possibilities for measuring or screening for adverse childhood experiences. So let's do a poll first. What age group do you hope to screen for? Is it a pediatric, under 5? Is it a child group from 5 to 12, adolescent, or are you looking at adults 18 plus? New developmental literature would put another group in there between adolescents and adults. The latest, they call them emerging adults. It's like 18 to 25 or 26. Group of young adults who don't quite think they're adults yet because they still rely on their parents, but I ignored that developmental category for now. Okay, so it looks like it's the majority are children or adolescents, a few, 1 in 5 for pediatric, and then about a third for adults. Okay, very good. And I have measures for all. So I'll show you a variety. And I'll have some recommendations as well, but so much depends on what your interest is in terms of how close you want to stick to the original 10 categories, or whether you don't care about that. If you think we should be more broad and talk about a variety of other adverse experiences, then you might be more interested in some of the newer measures. Okay, let's start with adult retrospective rating. Here's an example. This is from the ACES Aware, and this is very typical for the adults. This would be very much like the one that you could even do on NPR. And it's just really straightforward, right? Before 18, did these things happen to you? And you just check them off. And again, notice that the score is just, if this happened to you, it doesn't matter how many times. It doesn't matter how intense it was, if it was intense or more intense or less intense. It's just, if it happened, then you count it up and that's your total ACE score. It's very straightforward. Okay, let's take a look at another one. This is the ACEs too high. Again, I've included the links for these so that you can go out and look at other data for them and what they recommend about them. Very similar. The wording is slightly different, But again, it's you add them up and that's your ACE score on the ACES too high. But you can see the subtle differences in the wording for these measures. There's the behavioral risk factor surveillance system. This is an adult phone interview, and it was developed really to be administered on an annual basis to a broad sample of the United States population. The data can be accessed, and I've put their module that's related to ACES in the Google Drive, so you can see the way they ask the questions in those phone interviews. That may be helpful to you. Typically in these, when you're gathering data from a population-based survey, they leave out questions about sexual assault because they have no way of intervening. So their module, I think it might only include 8 of the 10 original. Then we have the Philadelphia ACE survey. The one thing I like about the Philadelphia work, and you can go look at their website to see about it, is they were very inclusive about the population. So they did a lot of work with the community in order to develop their methods for gathering the data. And so it was in some ways more of a community effort rather than like a researcher that's asking people questions. And so if you want to see sort of a process for how to do something that's more community engaged, this would be a good source to take a look at. The World Health Organization is getting involved in this and doing international assessment of ACEs. I've included that questionnaire in there. They are now working on gathering the psychometric data, the reliability, validity kind of data about their measures. But the measures are available and additional materials about, and one of the things you could learn from the WHO, the World Health Organization, they have quite a bit of advice about how to do this, how a worker in an international country could gather this data in a way that's appropriate. And even though it's focused on an international audience, I think their recommendations, their training, so to speak, could be useful for organizations if you want to see sort of a template for how you do this, how you help your workers or your organization to know how best to implement it. They're very good about those kinds of things, you know, being fully developed when you go. So you might take a look at that for the additional materials, even more than the actual instrument. Okay,
before you go on,
yeah.
Could I interrupt? I'm going to start with, we had a little hiccup getting the link to the Google Drive into the chat room. So I wondered if you might post that again for just a minute and let people see that. Is that possible? Or show that up on the screen again and we'll try it again.
How about if I just put it in the chat?
That's even better.
If I can get the chat to show up.
Down on the bottom.
And I'm just not seeing it on my screen, so there it is. There you go.
Awesome, thank you so much. And then we have a couple of questions for you too.
Okay.
There's a question about an instrument called Pearls, and would you recommend that?
I would. And in fact, it's one of the measures I'll show you here in just a minute in the child screening.
Okay.
I think it's a terrific measure, yeah.
Great. And then there's another question about, is there much benefit or research about using ACEs with older adults or seniors who often tend to underreport trauma?
Yeah, I didn't see any work with an older population. Now, that doesn't mean there's not any out there. Just in my preparation for this, I didn't come across that population. It seems to me that the bulk of the literature I've seen is moving it downward, right? Trying to prevent or address the consequences of adverse experiences early and not so much later.
Would you agree with the comment that there's underreporting in the senior population?
don't know enough about that to say that. It wouldn't surprise me, but that would only be clinical experience, not based on research.
Okay,
Yeah.
thank you.
Mhm. Okay, let's look at some of the child measures. So first, there are a variety of measures that assess PTSD or exposure to traumatic events for children and adolescents. I didn't review those because they weren't focused specifically on adverse childhood experiences. They're typically focused around DSM, Diagnostic and Statistical Manual definitions of post-traumatic stress disorder. But they tap into similar kinds of experiences, right? So in clinical settings, if you work in community mental health or an inpatient facility for mental health problems, you may want to consider one of those, and it may tap into the same principles, the same ideas, the same that people have had bad experiences and it's affecting them now, and then intervene. One of the articles, the O article in the Google Drive, provides a review of some of those instruments if this is your preferred direction. These tend also to be more commonly used by licensed mental health providers, right? And they may cost. So there may be other things associated with them. So now I'll turn to the ACE measurements. And here's the pearls. The person that said they're using the pearls. I thought I would actually show this one to you. I'm going to stop the share and then share again. I'll go out here and get the pearls. Okay. Here's the ACES Aware website. And you'll see they have the screening and the screening tools. So we're going to go there. And they're available in English and Spanish. They're available for adults and youth. So now here you have child and teen. So it can be a caregiver report, right? I'll just pick that one of those that are available. And you see that we're asking the parent, has your child ever lived with a parent or caregiver who went to jail or prison? And so forth. One of the things I like about the pearls is that it's the adverse childhood experiences and related life events stressors. So this is an example of one where they've gone beyond the original 10 categories, and they're asking questions about other related life event screeners. So, has your child ever seen, heard, or been a victim of violence in your neighborhood, community, or school? So they're getting into bullying. They're getting into experience discrimination for race or ethnic category or gender identity. Problems with housing. So this, to me, this idea that we're going to expand beyond the original research and look at other things that could result in negative outcomes, I think is really helpful. So Pearls is one of my favorites of those that I looked at, and it has some reasonable data about its reliability and validity too. Whoops. I got to stop sharing and go back to sharing the other one. Okay, another child assessment. This is called the whole child assessment. I'm not going to show you this one. This one is, it's more useful if you want to do a broad assessment and you want to put adverse childhood experiences within a variety of other things that they're assessing at the same time. So the questions aren't together in one module, they're spread throughout. And it is available in English and Spanish. So if your interest is in doing a broader assessment, then this might be one to take a look at. Again, I include the link so you can actually see the measure. And I believe I downloaded a copy of the measure and put it in the Google Drive as well. Okay, now here's the Yale Vermont Adversity and Childhood Scale. One of the things I like about this one is that they they have a child self-report, a parent report, and a clinician rating. So you can start to get at the different angles of looking at this. But you'll note in the measure that's up there that this doesn't match up necessarily with the 10 categories that were identified in the original study. So, was your child ever exposed to floods, tornadoes, hurricanes, earthquakes, or other natural disasters? See, this is adversity in childhood, but it's a broader range of things. They witnessed community violence or ever been bullied, or even an other category, right? Or war, armed conflict, or terrorism. So I picked the parent report to show here. I've included all 3 versions. There's actually a separate folder just for the Yale Vermont Adversity and Childhood Scale in the Google Drive that has all their versions. And I have a couple of, an article and a presentation, I think, maybe it's a poster in the validity section that provides some initial data about the Yale Vermont scale. It's also been used in some studies. So if you're not concerned about having the exact 10 categories, you're just more interested in a variety of adverse experiences that could happen, then this could be a good measure for you to use in in your setting. Okay, the Center for Youth Wellness ACE questionnaire. I'm going to stop the share again and show this one. Okay, here it is. The Center for Youth Wellness here, and you can see there's a variety of them. There's a child, a teen. And in this one, I thought I'd show you the teen self-report. So we've seen one where the parent reported on a child. We've seen the adult versions where you rate on yourself. Now let's talk about the teen one. And again, they have it in different languages. And you see that they go beyond again. So if you lived with a house member who was depressed, mentally ill, or attempted suicide, a typical ACE, one of the original study, or lived with someone who had a problem with drinking or using drugs, and then they have some additional ones. Have you been in foster care, or were you bullied, or did you have a parent die, or guardian? So this one too I like quite a bit. I think this one and the pearls are my favorites for sort of child-teen versions. Stop the share there and go back. Okay, so you see that they have both teen self-report and teen parent and child from the parent or caregiver. All right, Washington State University Extension has one. I tried to get these from them, but didn't have much success. But the reason that I thought this one would be useful is they have a parent version for Head Start. And I've put a couple of reports in the Google Drive about this so that you can see what they were finding. And I wish I had the parent version for you to see. I requested it, but they did not respond. And it looked like the person, the main lead on the research about it in their extension service had retired. So I'm sorry that I wasn't able to find that, but you may be able to contact them and see if they would share with you. So for those people that are looking for the under 5 group, this may be one that could be useful to you. All right. So that maybe this is a place to pause for a second and see if there are any questions about that show up in the chat about measures. I've given you some examples of adult measures, teen measures, child measures. I pointed in the direction of a pediatric measure for under 5. Some of the others can hit under as well, like the pearls and the child wellness. Does anybody have questions about the measures that I've given you an introduction to here?
So Ben, you would say all of those are equally effective in terms of your experience?
Some have more data than others, and it depends on what you want to do, right? So like the Yale Vermont doesn't hit the original 10, right? It's So I would use that if it fit your setting. I probably like the pearls better because it starts with the original 10 categories and then it adds other life experiences in addition. Same with the child wellness one. So I think, and plus they seem farther along in their development of reliability and validity data.
Okay. We do have a question in the chat room from Sarah. She asked if you would share any cautions you might have on screening.
Oh, that's a great question. And I'm going to talk a little bit about that in this integrating measures into practice. There are a few cautions. I shared that one set of cautions first, and that's like, whenever you're screening, you certainly want to make sure that you're understanding that just because someone's experienced something doesn't mean the outcomes are certain, right? So this is the point that we're going to help people. And let me talk about that in a second as well.
We
Any
have
others?
one more question. This will be interesting. Do any of these measures capture trauma, such as, just for example, a hypothetical virus pandemic?
Yeah, only in the sense that they put other. They don't have, so you saw the Yale, Vermont. They had a number of different things that you could experience, and then you could put another in there and you could write in what you had experienced. Most of them do not have a virus pandemic as one of the things.
Thank you, Ben.
But if you're using it in a clinical setting, most of the time, it's not like a research study where you have to use the measure exactly as it is. You could add an item. There's no reason why you can't add a question at the bottom of it. Just modify it and add a question that says, to what degree has the pandemic affected your, or added stress to your life, right? It's a clinical setting, you're gathering information, or just have your own separate question separate from it. So you don't confound it, so it's still separate and it has its own score, but then just ask the question. There's no harm in doing that in a clinical setting.
Because the anecdotal data could prove helpful as well.
Yeah, well, if I was doing a research study, then I would add questions and I'd make a little separate measure for stress related to the pandemic, right? We know what it's like for my faculty who work in my college, and they're like everybody else. They're trying to figure out how to do their job and help their kids do their homeschooling, and it's stressful. Everybody knows it is. So finding a way to gather that information when they come into your school or clinic or health center, but clinical data isn't the same as research data. I don't need to have a research validated report just to get the information and then have a conversation about it.
Right. So, thank you.
Yeah. So so first finding here is that there's many screening measures available, and they vary quite a bit, right? Some cover the 10 categories of adversity. Some don't even cover the same 10. They only do 8 because their sensitivity is about asking directly about sexual assault or sexual abuse or neglect, and the requirements that you follow up on that you do something about it if you find out. And they vary some in their data on reliability and validity. The ones I select, I think, have the most evidence so far. You can get adult and child, and there's both parent and youth report versions for teens. They vary quite a bit in terms of their associated materials. Some of them have quite a bit that gives you advice about how to do the screening. Some have none. You just get the measure and then it's up to you to figure it out. Some of them were developed specifically for screening in like pediatric settings or other mental health settings. Some were developed for research use. So, and there are cautions, and I put those in slide 12. We've already talked about them. And then some people are saying that it's important to assess resilience and protective factors at the same time, so that you're, now, even just from a strengths-based perspective, right, it makes sense to gather information from someone about the ways in which they're managing, handling, coping, thriving, surviving their life at this time when you're asking them about these difficult situations. But let me give you one example here. So here are my choices. I think the ACES Aware would be okay for adults. I like the Pearls or the Center for Youth Wellness and the Yale as my child examples. I couldn't really pick a specific one for under 5, but I think the Pearls and Center for Youth Wellness cover pretty low, so they're okay to use there. Now, here's some advice about implementing. That goes back to this that previous question, Linda. So there are published studies showing where they actually asked parents, and this is particularly important when you're asking a parent to talk about what the child has experienced, and the parent may be the one that they're talking about their own mental health issues, right, that may be influencing the child, because they're the one that has the depression, and you're asking them in the screening questionnaire, does your child live with someone that has a mental illness? So they wanted to know whether caregivers are receptive to this. And this study, the studies have been done primarily in pediatricians' offices, but I think the findings really apply to other settings. And basically the parents are saying that they feel comfortable talking about these adverse childhood experiences as long as there's a trusting relationship. They feel like you really care about them, you have their child's best interest in mind. And they understand also that it may be of value to their child's care, but they don't know about the potential lasting health impacts of exposure. So if you're ready first, if you are clear about the fact that you have a good relationship with them, and second, when you have the conversation with them, if you can, give a brief 30-second or 1-minute explanation that there's studies that suggest that youth under 18 that have these experiences are more likely to have health problems in their life. Even things like traumatic brain injury later in life or cancer. Then that helps them to see why it's important. And so then it provides an opportunity for you to provide some support to them, right? And then this key idea, caring, supportive adult, right? Over and over again in the resilience literature, a single caring adult, doesn't matter if it's a teacher, an uncle, a coach, a mental health therapist, boys and girls club, volunteer, a single supportive adult provides such an important role for children and youth. Can just really protect them against a lot of things. They need to be consistent, right? But that caring support is really important. Okay. So you're going to screen. So you got a number, then what? You have a 25-year-old that just walked into your office. You gave him this in the screening along with some other things. What's our goal here? Well, for adults, it's to reduce traumatic shame. That's the real end goal here. For children, we're trying to prevent any additional adverse experiences, and we're trying to prevent the predicted consequences. And that happens in part by increasing resilience and noticing protective factors. So I'm going to say a little bit about this. So this is what Gilgoff recommends in their review, that pediatricians, and I think this applies to other settings, they first can identify children and families in need, and then second, they can offer empathetic and science-based guidance. And what that guidance includes is just basic practical information, things like healthy relationships, sleep, nutrition, physical activity, mindfulness, going out in nature. So just as base. So if you're if you're one of the people on this presentation, and you're not a licensed mental health provider, and you're not going to provide trauma-focused treatment or intervention, then the things that you can do are provide empathy and just guidance about basic things like relationships and sleep and nutrition and physical activity. And then you refer. You refer for these other resources if more intense intervention is needed. And if you are one of those licensed mental health providers, then you can provide this kind of trauma-focused treatment when it's needed. Okay, now this study just fascinates me, and this was the follow-up that Felitti did to their very own study. I've included the reference to the article. It's not the research article, but it's to where he's discussing it. And it's the thing that makes it so interesting is 135,000 adults. And they're taking a medical history and their questionnaire at the same time. And in the questionnaire, there's an ACE module that asks them about experiences before 18. And then you see what it says here. And I'm just going to read it because I think it's so interesting. Our basic approach was to say in the exam room, I see on the questionnaire that, and then you say you endorse this item that said that you were neglected when you were a child. Can you tell me how that has affected you later in life? So just a simple open-ended question after noting that they checked an item. And then we listened, period. So these are medical providers, and what they did was ask an open-ended question and then listened. Later, we learned from patients that our apparent acceptance of them after hearing their dark secret was of profound importance. After lengthy consideration, we came to see that asking, initially by an inert mechanism, followed by face-to-face listening and accepting, was a powerful form of doing. In other words, we had come upon a mechanism for reducing traumatic shame, which shame had the secondary effect of causing stress-related symptoms and hence doctor visits. That was the only intervention they did. They just noted it and listened. And that simple intervention reduced the subsequent outpatient visits by 35% and emergency visits by 11% in the year following the visit, compared to the prior year. So even just the simple act of recognizing it and listening. Now, again, this study is with adults, so the degree to which it'll apply downward to adolescents and children, meaning you're going to need to include parents and others, for example. But still, you get the idea. For those that are working with adults, the 30% that want to screen there, you can see that even this basic idea can really be helpful. Now, and then if you have referral in addition to this, then you've covered a wide range of possibilities. I think this really fits with Brene Brown's idea, right? That if we can share our story with someone who responds with empathy and understanding, shame can't survive. And I really believe that, because it's accepting them. It's accepting someone who's had these kinds of experiences. Okay, so in summary, I think you select a measure. You consider including resilience or protective factors with that ACES screening. Some suggest that you should include it within a battery rather than a standalone assessment. They say it's too shocking or abrupt to have it just by itself. And then you have a plan for an in-person follow-up. At a minimum, you should ask and listen. So ask with an open-ended question where you say, I see that you checked this. Tell me how it's affected how it continues to affect you. Or you can provide a guidance like the pediatricians did. That's more about sleep and nutrition, physical activity, being in nature. And then you refer or treat in-house if you have those capabilities when necessary. So now some limitations. Maybe I should stop there and just see if there's any questions, Linda, before we move on to the limitations. You're muted.
I apologize. I thought I'd taken care of that. Ben, were you able to review or see anything on ACES resiliency measures? And if you did, what's your opinion on their appropriateness, validity, and reliability?
You know, I didn't specifically prepare for that on resilience. There are some strength-based measures out there that I've seen in the past. There was one out of Illinois that's been around for 20 years that's quite good. The strengths and difficulties measure, I think,
Mhm.
and I really like it, and it has good psychometric properties. Um, I mean, we'd need to prepare for another day. I was asked to prepare on adverse childhood experiences today. You give me another 15 hours, I could probably do it. Yeah.
We will definitely keep that in mind for the future. Thank you.
Yeah. So some limitations about this. First, ACEs measurement is static, right? If you had these experiences, you have these experiences. Every time you fill out the measure, you're going to say, this happened to me. It's not an outcome measure. You don't get to say to a 40-year-old, have you had these experiences before 18? And then a year later, have you had these experiences before you're 18? They're the same. They didn't change because they're 1 year older. They're 41 now, but they still had those experiences before 18. So some might say that it's useful information to know that you're going to deal with these childhood experiences, but maybe it needs to be paired with a symptom measure. What symptoms are you experiencing right now? Or a strength-based measure. What strengths are you using to manage your symptoms right now? It's probabilistic. The presence of the ACE doesn't necessitate a negative outcome. So it's more about how they're handling them, how they're managing them, how they're making meaning out of their life. It's interactive in the sense that resilience and protective factors moderate the impact, and there are other co-occurring things that may exacerbate it, like poverty. So if someone's in poverty and they've experienced these things, they lose their job and they experience these things, then that may exacerbate the impact of it. They have adverse childhood experiences, and then a pandemic comes along, it may make it worse because they're already under stress, they're already experiencing these things, and then we aggravate that by having them isolated and in circumstances like we're in today. And but then about categorical events for which meaning is modifiable, treatment can reduce the traumatic shame and help people to thrive even through adversity. Okay, I already told you about the Google Drive. I just repeat it here. Maybe I could put it in the chat again. And finally, just thank you for your work with individuals who have adverse childhood experiences. The group that's on here today, you're interacting, you're helping people. You're doing this work face to face, and I'm appreciative. I've done some of that work myself as a clinician, and it's hard work. It's tough work for the clinicians too, and it takes a toll on us, and we need to take care of ourselves. But we're blessing a lot of people by helping them to work through experiences that were not their own choice when they were kids, right? And so thank you for the work you're doing to help those children. Then here's my contact info if you want to contact me. That's it.
So Ben, we have some questions if you're ready for those.
I am. I may not have answers, but I'm ready.
That's okay. They'll be interesting questions to ponder together then, won't they?
Oh, yeah.
Lonnie asks, do these measures identify known numbers and disparities in the healthcare data?
Known numbers?
Known numbers and disparities in the healthcare data.
Do you mean the fact that some people have access to help and some people don't? Disparities in healthcare availability?
That's what I would tend to think, unless Lonnie would like to clarify further yes. Lonnie is saying yes, that's what he's talking about.
Yeah, no, the actual measures don't give you any information about what services are available. And that's a really important question, really, in one sense, right? It's you could have a really good measure and still not have access to good services, right? You could screen and find out somebody needs those services and they wouldn't have access to them. That's a bigger systemic issue and one that needs to be tackled for sure. But you won't get it from administering the pearls or the adult measure. That won't give you any info about those disparities.
So a different it's something not included in these particular measurements.
No.
Excuse me. We have another question from Kim. What is the most recent study connecting ACES with chronic health problems?
Ooh, I don't know. I mean, there's so many now, and they're expanding. Like the one on maternal anxiety and depression that I talked about earlier. So they're expanding that. It's a very recent study, and I put it in the Google Drive so you can see it. But I haven't looked at the most. There's, like I said, there's almost 7,000 articles since 1998. I'm not sure what the most recent one is.
Okay. Let me check our. Nadine asked, are all service providers using the ACES assessments?
In your county, I don't think so, but that would be something, a question more for, I guess, which services. I mean, there's probably no one that collects, maybe the Children and Family First Council or something like that would have a sense for the breadth of that, right? But or the mental health agency. My guess is I doubt that.
It's an interesting question.
Yeah. Should they? That may be even a better question, right? Are they all? Probably not. Should they be? That's a good question. Some agencies ought to be for sure, right?
So given that, and given that we're not really clear on that, what would you suggest to encourage the use of that? It sounds like you're very supportive of it. What would you encourage to encourage that?
Well, like for example, if I was a pediatrician, I'd want to screen. If I was at a community mental health center, I'd want to screen. If I was at a juvenile detention facility, I'd want to screen. I guess it depends on the setting. Probably child welfare, caseworkers want to screen. Any place where I wouldn't screen if I didn't have access to some services though to provide the people, because what's the point of screening if you're not going to do something about it?
Identification without treatment isn't necessarily going to be helpful, I think, is what you're saying.
Exactly.
Yeah.
Yeah.
We have another question. This is an interesting question from Chelsea. She said, is there anything that measures the degree of severity of trauma and the change as time passes?
Yeah, some of those post-trauma questionnaires that I referenced but didn't cover, they will give sort of the intensity of symptoms now that you could administer over time and show improvement in their trauma-related symptoms. The other approach is to use a more general questionnaire and not a trauma-specific questionnaire. So for example, I just looked at a study, this was in adults, but they used a post-trauma questionnaire that had 17 different symptoms, like nightmares being one of them, right? Or intrusive thoughts. And you could look at the intensity of those when they entered treatment and the intensity of them when they exited treatment. And they could even show that they went from meeting the diagnosis of post-traumatic stress disorder to sub-threshold or no diagnosis. So you can do it that way. Or you could get a more general questionnaire like the Symptom Checklist 90, which is an adult measure, or the Youth Outcome Questionnaire, which would be a youth measure. But it measures a broad array of symptoms, not just post-trauma symptoms, and you could show change in those symptoms pre and post. So there's sort of two approaches. And it depends. If I'm an agency where I work with exclusively people who are coming in with trauma, I might use the more narrow one. But if I work with a wide range of youth or adults, some coming with depression, some with anxiety, some with trauma, some without, then I might use a more general questionnaire. And that's a more broad outcome-oriented question, and that's actually more central to the kind of work I do.
Okay. We have another question along the same lines. I think I could probably answer this now that we've listened to you, but do you think that the ACES assessment is a good practice as part of an overall assessment for both youth, adults, and for seniors?
Yes, especially if you're working in a setting where you're likely to encounter people with adverse childhood experiences, right? But even your regular doc, I mean, that's what they did in the original study, in that study with 135,000 people, right? Came into the HMO to get a physical exam and they screened, and they reduced the number of subsequent visits related to the stress experienced by people. So I think
And
there's,
that was just in general health practice. That was not,
that was HMO. Yeah, that was
yeah.
your HMO.
You
People
know,
coming in for a physical exam, and they screen for ACEs as part of a questionnaire.
I was really surprised and the acceptance of that dark question, that dark secret in your life, and the acceptance of it, the non-judgmental approach to it, the just listening part.
Mm-hmm.
When you think about the impact that shame can have, that was 35% is an incredible number.
It really is. Yeah.
Well,
And they're very narrowly focused on a very specific outcome, right?
yes,
Visits to your doc for health related things, the flu or a cold or other things. Think if you had outcomes that were related to mental health. I mean, there's a broad range. Maybe if we tracked how much they drank or, other things, use substances, right? Those might have
right.
changed too.
It's a very good point. It's kind of surprising it may have had that much impact.
Yeah.
We had another question, and this is toward the resiliency factors. Have you studied what factors lead to decreased severity? And if you have, what resiliency factors can be fostered in treatment or in a classroom or wherever so that the impacts of the trauma can be decreased most efficiently?
I think some of the, let me answer this in two ways. First,
Mhm.
no, I haven't studied it. Have I seen some articles about it? Yes. Am I an expert in it so that I've read dozens and dozens of articles? No. So, with that caveat, there are a number of resiliency factors that have been shown repeatedly to help young people. The number one, in my view, is that caring, supportive adult, a relationship with a caring, supportive adult. Some of the resiliency factors are related to environment, uh, and uh, and some are related to child-related things. If they have a talent or a strength that they can center on and base their self-worth on, that helps them. So they're really good at math, and they can center their identity on that kind of thing, those kinds of things. But the resiliency literature has a number of categories of kinds of things that you can focus on. In treatment, personally, you've got access to the person, so I'm helping them to have a different view of their experiences and to develop their internal coping strategies. Plus, I'm trying to help them to reach out and connect with other resources in their community. So those social supports would be especially valuable in addition to what you're doing with them personally. But you have the greatest access to the individual. So if you can get them to reframe it, to think about it differently, to have confidence in themselves, then that's probably your best avenue at that point.
I think you and Mary, she mentioned something very similar to me right after this morning's session and said, be sure that when you talk about ACEs and the recognition of the problem, that you also talk about resiliency and those counter factors, just as you talked about. So
Yeah.
I think you both were very aligned on the importance of looking at both sides. There's another question. What is your overall takeaway as a mental health professional researching ACEs and this topic? What surprises or interesting finds in the research did you identify that perhaps you didn't expect?
Well, the Counter ACEs article was certainly one of the most interesting things. I expected to find, even in that model, that they would find that adverse childhood experiences still had some unique effect on outcomes independent of the counter counter ACEs, and the fact that the counter ACEs were so powerful was surprising to me. So it's the combination of the two. It's the combination of the resilience, protective factors, and vulnerabilities and experiences. It's a complex formula that sometimes leads to poor outcomes and sometimes the better. So that was certainly one of the surprises for me. I was also surprised by how rapidly the measurement development happened in just a few years, right? There are a lot of people interested in this and doing, so in a decade, we should know a lot more, I guess, about how, especially in young people, because the research will move down.
Maybe one of the positives we'll be able to take away from this pandemic is those learnings and understanding how to build that resiliency from a young age.
Yeah, hopefully. I mean, we have a common adverse experience, don't we? All of us.
We do. We absolutely do.
So.
Hopefully there's a light at the end of that tunnel. There's another question, Dr. Ogles, and that would be, do you endorse the instruments with less ACEs listed, 8 or more, I'm sorry, I'm trying to put punctuation into the question, so let me try it again. Do you endorse the instruments with less ACEs listed, like 8 or more that have 17? Would you recommend always asking an other ACEs category question?
Well,
Assessment.
Yeah, see, I think this is depends on your circumstance, right? So the places where they've done just the 8 is where, like they're doing a telephone survey of adults, and they don't feel like it's an ethical thing to do to ask someone about sexual abuse when they don't have an avenue to provide them with any help if they answer yes. So it's more of an institutional research review board and ethical problem, and that's why they're limiting their number of questions there. If you're working in a mental health facility where you have the capacity to intervene with someone, then I wouldn't recommend using just the 8, because it's useful to know whether or not they were abused as a child, and it's the kind of thing you might screen for anyway in your regular intake. So then I would recommend using, so I like the Pearls, for example, for children, because it does the original ones, and then it asks for other related adverse experiences. And I think that's more useful in a clinical setting. So I'd probably prefer that.
Thank you, Ben. There's a comment from Nadine, and she said it would seem that the information, assuming that she's referring to the ACES survey, would be very helpful in directing treatment, which is what I think you've been saying to us.
Yeah.
We have another question. In discussing sexual abuse, does the factor of being abused by an adult or a child change the impact on the individual?
Well, it certainly does. And in some of the questions, they actually specify this, right? So they'll say, was it someone 5 years older than you or more? Like they'll say, did the abuse occur by someone that was at least 5 years older than you? With the sexual abuse literature, there's a bunch of things that influence the degree to which it's impactful, right? How repeated it is, how invasive it is, how coercive it is, who is doing it, the age difference. There's just a bunch of things that influence the degree to which it's harmful. It's all harmful, but it's all harmful. But there are factors that influence the intensity, if you will. So, and some of the measures take that into account, and some just ask if it's happened. And then you would have to follow up clinically if you're going to do that. Now, so let's say I'm in a setting where I'm not a licensed mental health professional, even the pediatrician. I find out they've been sexually assaulted. I say, I noticed that you endorse this. How's it affecting you? I give them some advice about nutrition and physical activity, and I make a referral to a licensed mental health professional to go talk about it more. So that's how I'd handle it if I'm in that setting. If I'm a mental health professional, I just begin to address this and say, is this something that you'd like to talk about in our treatment? And if they would like to, then I'm going to need more information, and then we can talk about the factors that may have influenced it and how we're going to help them from there on.
Very good. We have, I think we'll take just one final question, if you're ready, Ben. And
Okay.
Lonnie is referring to some of what we're seeing in our national news these days, and he's asking, how can we develop a model beyond the talk to really begin understanding the uncomfortable voids that we sometimes have in our diverse differences?
So
How do we address those with each other if we're trying to develop greater understanding? What would you suggest?
for diversity, diverse issues? Oh,
It's a big one, isn't it?
yeah, it is a big one. And I think I like Brian Stevenson's idea that proximity is crucial, right? You just can't get to know people unless you're with them and you listen to them and you're around them. So it means Stevenson says you got to be proximal, right? You got to be close to people, and you have to listen. So my experience is that until I know someone who's different to me, until I sit down and break bread with them, till I ask questions, till they trust me to be able to tell me what their experience is, until I really listen to them, I don't really have any idea what their experience is like. And so that really doesn't have anything to do with adverse childhood experiences, but these experiences affect different populations differently for sure. And we gotta consider privilege and diversity within the context of thinking about these things. And my view is you got to listen, and you got to know people, and you got to invite them to tell their story. That was probably more meandering than you expected to hear, but that's my take on it.
It's your personal experience, and I agree with you. I think it's based on relationship.
Yeah.
Dr. Ogles, you have been fascinating today. There is much more to take away from the work that you've done, and so appreciate you being with us. I know that our hope for our sponsoring groups, the Butler County Mental Health and Addiction Recovery Services Board and the Butler County Family and Children First Council and 4C3, is that we're able through this training today to both boost the resiliency of those listening and also give great information that helps people in their treatment and spreads this great work throughout our county. So thank you for being with us.
Mm-hmm.
We are going to take a moment, and I'd like to ask everyone to go ahead and save your chat because there's great resource information in there, including the link to Dr. Ogles' report today. And we're going to take a moment to do our resiliency booster moment. And I'm going to, in just a moment, introduce Lori Brown for that purpose. I want to thank you for being with us for this session. Let's give Dr. Ogles a round of applause in our private settings and say thank you for sharing your expertise and wisdom.
My pleasure.
We will be closing after this, and then please go back into your registration link that you were sent at 2:30 for our final session of the day with Sarah Buffy. Looking forward to it, and so glad so many of you have joined us today. Again, please take a moment to go into your chat room, make sure that you've saved that information, and if you're applying for CEUs, do not forget to complete your survey when you leave today. This is Lori Brown, the Director of Student Services at Lakota Local School District. Lori, the floor is yours.
Thanks, Linda, and thank you, Ben, for a great presentation. Similar to our morning session, we wanted to try to find some stories of resiliency to share that are personal stories from people in our community to just kind of nail down this idea of resiliency building in all of us. So this morning you heard from Alexis, who was from NAMI, and she shared her personal story for the second booster shot, as we're calling them. I want to introduce to you Eric, who is from the Mobile Response and Stabilization Services put on by Butler Behavioral Health. And he's actually videoed, and I'm going to share my screen in just a second. And he's going to be sharing, he works at MRSS, and he's going to share some stories of resiliency and the work that he does. So I'll share this video. It's about 3 minutes long, and then we'll jump off from there.
I'm Eric from the Butler Behavioral Health MRSS program, and I'm here to tell you a story about a family who found themselves in a situation that they'd never been in before, and the efforts they made to overcome it. So this family lived outside of Ohio, and in March of 2020, their elementary school-aged child began to experience some deteriorating mental health issues. And it was around this time that he was also removed from school and was doing virtual school. So things were stable-ish for a little while, but by the time school was out and the summer began, he was having a pretty hard time at home. And the parents were not sure what to do about that. Coincidentally, they moved to Ohio that summer into our service area, and one night things had gotten so chaotic at home that they called the crisis line, and one of our therapists was able to get there pretty quickly and help them de-escalate that situation, but also worked to have the child placed at Children's for a brief stay. And it was there that he got connected to some other services, to a psychiatrist, and things started to improve pretty rapidly. And the parents began to learn some different skills to help with this new situation that they had found themselves in. And they took to it with just readily. They were very engaged in the process. So things started to go pretty well, but as we tend to know, these things don't always kind of resolve that easily, right? So it was a couple months ago that things started to deteriorate a little bit again, and the mom called the crisis line, and we responded, and we were able to help them with with a lot of support from mom. Dad was out of town at the time, to work on de-escalation, and compared to the last time we went out there several months prior, um, we were able to get this child stabilized really quickly, and he was very engaged in the process. He almost expected or anticipated what was going to happen and went along with it, and mom knew what to do as well. So with those combined efforts, they were very effective at de-escalating him in that moment, and there was no follow-up needed after that. They were able to continue with their regular services with the psychiatrist, and things went well.
All right, so with that, another sample of a resiliency story, and we'll see you back here in just a little bit. Oh, I'm sorry, looks like Linda has another item.
One moment, well, two things. Thanks, Lori. That was great. Please tell him thank you for us. That was great to hear. So I understand there are a few people having trouble saving it in their chat box. If you'll open your chat box and go to where you would type a message in at the bottom, take your cursor straight across. There should be a small box with 3 dots in it, and it will say more. And when you open it up, Save Chat is the first option. So hopefully that's helpful. Again, bottom of your chat box. There is no box with dots. So we will try to save it and we will send it out to people. I'm not quite sure. Thought I knew a lot about Zoom, but I'm not sure why you don't have that. So we can send out the chat to everybody when we send out a follow-up. Hopefully that will be helpful. Thanks everyone for joining us, and we will see you back here for our final session at 2:30. Dr. Ogles, thank you again.
My pleasure.